Hey everyone, one of the most common requests I get is to talk about a day in the life of me as a cardiothoracic anesthesia fellow. What does my life entail in terms of workflow? What time do I wake up? What kind of cases do I do? Things like that. So the kinds of cases I do range from coronary artery bypass grafts or CABGs to aortic valve, mitral valve, tricuspid valve replacements or repairs, mechanical circulatory support devices like Impella placement, VAD, centromags, things like that, heart transplants, lung transplants, esophagectomies, extrapleural pneumonectomies, and then everything in between regarding structural heart, so MitraClip, Watchman devices, things like that. And my training is primarily centered around trying to master all of these procedures going into the future because that's what my job is going to entail. Coupled with my ICU fellowship, I feel like there's a lot of synergy between the two disciplines and I have no regrets. It's a fantastic career. It's very dynamic. You never know what to expect. So in that sense, I'm always excited to go to work every single day. But just to kind of fulfill my obligations here, I'm going to walk you through what a basic day in the life of me looks like when I'm doing a case by myself. Typically, that happens on a day where the cases start later because the residents have didactics and whatnot. So this is basically a walkthrough. Please leave comments with questions. I am putting this together sort of in a piecemeal fashion, so I apologize for that, but hopefully this gives you an idea of what a day in the life of me looks like. Each day I wake up around 4 a.m., try to get some coffee going while reading a journal article or a chapter in a book or something. I try to read about my patients to see if anything changed overnight, and then I start to get ready for work. Then I start making my way out of my apartment to catch the MBTA, our public transportation train system here in Boston, to go to the hospital. It takes about 15 minutes, which isn't terrible, especially since I don't have a car. This has been a really good way for me to get to the hospital. Once I get to work, I make my way to the break room, put my bag down, grab my pager, and go to the operating room. So setting up the cardiac ORs can be very complicated depending on how much or how little you need. Sometimes you just need an arterial line and a central line. Other times you need a venous introducer for a PA catheter, cerebral oximeters. Patients will be getting somatosensory evoke potentials. You'll need to do a TIVA style anesthetic. You need your induction medications, sometimes a double lumen tube as well as a single lumen tube, lots of different things. So here I show you some of the basic things that I often have to set up. Usually the first things I grab are my supplies from my central line and arterial line. The arterial line I do in the pre-op area and the central line after induction of general anesthesia. Then I'll proceed to get all the monitors ready. So here's the cerebral oximeter, the Edwards Life Sciences box for the PA catheter, our standard ASA monitors with PA, CVP, and arterial line tracings, the ventilator, and some basic airway equipment that's already been checked. In cases that I'm expecting a difficult airway, sometimes I'll have a video laryngoscope like this glide scope on standby. I use a lot of different medications in cardiac anesthesia, but I really try to pay attention to doses and meticulous labeling for patient safety. It's very important. And last but not least is my obsession, the transesophageal echo or TEE. At the time of this video, cardiac anesthesia fellows are actually getting board certified in advanced perioperative TEE, so it's very important for us to know this skill. So around 6:30 or so, I'll go to the pre-op area, consent the patient, get a peripheral IV if they haven't been inpatient, do the arterial line, get them back to the operating room around 7:10 or so. We'll do a surgical pause where we kind of verify the patient, the procedure, make sure everyone's on the same page between the surgeons, the anesthesiologists, the perfusionists, and the circulating nurses. Once all that's done, we induce general anesthesia, put the central line in, do the case, go on bypass, go to the ICU, do all that good stuff. Usually there's a second case to follow as well, so once all that's done, I'm usually heading home in the evening time around maybe 5, 6, sometimes earlier, sometimes later. But it just depends on the type of case and it depends on if you're any kind of special call. So if there's transplants or dissections and you happen to be that fellow that's on call, you'll probably end up staying and doing them, if not getting called in overnight. Once I'm dismissed by the board runner and if I'm not moonlighting, I walk out through the Harvard quadrangle, catch the same train back home, which takes about 15-20 minutes, and then hopefully try to get some cardio in before getting some studying in, before getting some dinner in. So that's basically it. Obviously, I couldn't go into specific patient details or anything like that because of HIPAA, but that's kind of an outline of a routine day without any disasters or anything like that. If you have any questions, drop me a comment, and thank you all for watching. I'll see you all in the next one. Have a good one.